Hello, and thank you for coming. I'm going to go through some slides fairly quickly because we've only got half an hour, and I do want to leave some time for questions. So I'll go through fairly quick. If you want to, we can pick up on things in the question time. So the things that I'm going to cover, I'll give you a little bit of background information on dementia. I'm going to talk about how patients with dementia present to GPs, how to take a history from someone with memory loss, what investigations you should request, when to refer to secondary services and what to put in the referral, what secondary services can offer, what to do with patients who refuse referral, and a little bit about the role of the GP after diagnosis. So dementia is underdiagnosed. 2009 England, the figures were probably 31% of people with dementia that were registered on GP lists. 2012, the estimate is that 41% who are living with dementia have a diagnosis. There is quite a variation in different parts of the country, but we do know that it's underdiagnosed, that a lot of people don't actually get a diagnosis and get the help that they need. The National Dementia Strategy was published in February 2009 with a 5-year plan, 7 interlinked objectives and £150 million of extra funding from the government. And the key themes of the strategy were improving awareness, early and better diagnosis because of the problem with the diagnosis that I mentioned, improve quality of care and delivering the strategy. And then there's the Prime Minister's Challenge, March 2012. And he said that people should receive a timely diagnosis. The same theme keeps coming through, that people should get the diagnosis, better quality care, reduce stigma by increasing understanding and awareness across society, and build national capacity and capability in dementia research. The QOF Dementia 2012 to 2013, some of you will be aware of it. Are most of you GPs, or are you some of you GPs? Different backgrounds. The QOF for dementia, there are 3 things listed there. The practice can produce a register of patients diagnosed with dementia, so that would be a GP practice actually having a list of people who had dementia. Percentage of patients diagnosed with dementia whose care has been reviewed in the previous 15 months, and the percentage of patients with a new diagnosis of dementia recorded over the last year who'd had all the appropriate investigations. So how can GPs improve diagnosis rates? Well, be aware of the problem, be vigilant for signs of memory loss. Relatives may well be aware when the patient is not. The first thing when I see a new patient, the first thing I ask is, are you aware of a problem with your memory? And probably about half of them are, but the other half have no idea that they've got difficulty with their memory. So often it's the relatives that can tell you. Encourage patients to seek a diagnosis. And remember that the prevalence is 1 in 14 over the age of 65, and the older you are, the higher the rate is. So when you see an older person, have a high index of suspicion. So how patients with dementia actually present to GPs. Some of them will actually come and ask for help. Some of them do realise they've got a memory problem and will come and ask. The family might be concerned, and then the patient may or may not agree. And there's quite a lot of situations where the family is very worried about the person's memory, but they will not accept that they've got a memory problem and won't see anyone about it. And then concerns can be picked up by others, district nurses, community matrons, social services, all these people who are working with the elderly in the community, care home staff may pick up the memory problems. But there may be some people who are isolated and elderly who don't have anyone who can express concerns. So if you do come in touch with people like that, it's good to think about dementia. How to take a history from a patient with memory problems. You want to ask, when did the problems begin? I mean, when I take a history, I always try and have an informant. When we write to people and invite them to the clinic, we ask them to bring somebody with them. If we see them at home, we try and arrange for a relative to be there, because they often won't know the answers to they often say, there's nothing at all wrong with my memory and I do everything myself. But yes, what you want to know is, when did it start? How does it affect daily life? Can the patient shop? Can they cook? Can they wash themselves? Can they get themselves dressed? Are there any risks? Dementia is quite a dangerous illness. People burn saucepans, they leave the gas on, they wander off and get lost, they walk in front of cars. People with dementia can be dangerous both to themselves and to others. So it's good to ask early on about the risks. alcohol consumption, and that may escalate as the patient forgets the number of drinks they have. So somebody who's had a little glass of sherry every day will have it and then have it again and then have it again, and the consumption can rise up. So we always look for information about alcohol. And is the patient still driving? Is this safe? People with dementia can drive, some of them can drive, but you do need to think about it. And again, the patient may not know, they may be very dangerous in the car but have no idea, and it's good to ask a relative how the driving is. And an informant history, a history from a relative or a friend, if at all possible. As I say, people with dementia will answer all these questions, but they may not know what's actually going on. And then a mental state examination, look for obvious signs of memory loss, repetitive questioning, and often in a consultation pretty quickly on you can realise that people are asking the same questions or not remembering what you said earlier. Mood changes, depression's more common in people with dementia, so we always look for that. And then there's something called the mini mental state examination, which is the thing that's most commonly used to test people's memories. That's a 30-point test. 27 is the cut-off, but it is influenced by intelligence and education. So I used to work in an inner city area, and I'd see people there with a mini mental of 25 who didn't have dementia. I now work in a sort of posh part of Leeds, and we get people who get 30 on the mini mental who have got dementia. So it's not an absolute test, but it's a help. And the other thing that we look for is psychotic symptoms, such as hallucinations or delusions. And if you actually ask, they're quite common in dementia. A lot of people with dementia see things, hear things. So what investigations should you request? Full blood count, thyroid function tests, serum B12 and folate, glucose, urine electrolytes, calcium, renal and liver function, and an ECG. The ECG is done because the medication that we prescribe, it's good to know if people have a heart problem before you prescribe it. We do pick up an amazing number of abnormalities with these ECGs, including I've picked up 2 people in complete heart block. So it's worth doing. I know people, not everybody thinks you need to do an ECG in people with dementia, but because we've picked up so many abnormalities, we always do them. Who to refer to secondary services? Anyone who believes they have a memory problem and can offer you some sort of evidence. I did get one person referred because they bought a new mobile phone and couldn't work out how to program it. That was not, I didn't think that was evidence of dementia, but on the whole, if they can offer some evidence. Anybody whose relatives or carers believe they have a memory problem and can offer some sort of evidence. And I do now see quite a lot of worried wells. I work in a very middle-class area, so I see a lot of people who think they might have memory problems. I can't detect anything. I send them to the psychologist and they can't detect anything. But I follow them up long term. I see them sort of every 6 months, and actually the majority of them do go on to develop dementia. So I think there must be people who can pick up very subtle problems with their memory that we can't on testing. So I just see them every 6 months. What are the benefits of referral to secondary services? Well, diagnosis can be complex, so especially now we're getting the worried well. Sometimes it's completely obvious that somebody's got dementia, but quite often it isn't. Patients mostly want to know whether they've got dementia or not, and that has changed over the time. I've been a consultant for a long time. When I started, you would never have told anyone that they had dementia, and people would have been devastated. People are still upset, but they see it as a diagnosis that will open doors, and they see it as something that will help them plan for the future. So, of course, I see a selected group. I see the ones that come to me, but the ones that come to me do want to know. And nearly all carers want to know, because if you're a carer living with somebody with dementia who won't admit they've got it and hasn't got a diagnosis, so you can't access help, it is very difficult. So the carers really want to know. Medication under the NICE guidelines should be initiated by a specialist. And a specialist diagnosis also helps to open the door for various benefits. People are often entitled to the attendance allowance, and you can get a council tax rebate with a diagnosis of dementia. We can do functional assessments, so we have a team of occupational therapists who can do functional assessments. We can provide specialised support, social workers and community psychiatric nurses. Most people with dementia don't actually need a specialised social worker. Sort of 90% of them will be fine, but there are a few of them where there are very difficult issues, usually to do with not accepting any help. where our social workers are good. And we can address the psychiatric comorbidity. As I said earlier, depression is very common in dementia, and so are psychotic symptoms. So we can look at those. Information to include in the referral, the problem with some sort of evidence, such as forgetting to come to appointments. That's a common one I get from GPs. GPs pick it up when people make appointments and don't turn up, and they're people that previously would have been reliable. It's good to know about the presence or absence of known risks, particularly driving, wandering, leaving the gas on. That's just because we see people very quickly. If we know there's a risk, if I get a referral, somebody is still driving and people are worried about that or leaving the gas on, we'll see them very fast. So it's good to know about that. Past medical history, because that's important with the treatment we give, and again, the patient may not actually remember their past medical history. List of medication with any compliance issues. Allergies, again, the patient may not remember they're allergic to things. Anything you know about social support and any other background information. Often GPs know a huge amount about patients and families, and that can be very helpful to us. So a patient who refuses referral or treatment, that's a big problem. May be able to use a relative to engage them. Remember, the rules of confidentiality still apply to patients with dementia, so you still have to be, as a healthcare professional, you still have to be careful with people with dementia. It doesn't automatically mean that you can talk about them without their permission. A home visit from the memory team might be better, and sometimes if people are really awkward, we'll go with the GP, and then sometimes they'll let us in if we go with the GP. Sometimes people will accept an assessment in a GP surgery. Sometimes they won't come to a psychiatric unit, but they will let one of us see them in the surgery. And sometimes nothing can be done until risks are so great that assessment under the Mental Health Act is warranted. And we do get people who completely refuse to engage with us and who are very risky, and in the end up being sectioned into hospital. It's rare, but we probably do, I don't know, about one every 3 months in my catchment area. So it does happen. Assessment in secondary care. Services vary over the country. They're arranged in lots of different ways. In some teams, initial assessments are done by nurses. Some teams, it's still all doctors. They may be seen in the clinic or they may be seen at home. The clinic is more efficient. It's quicker, and you've got immediate access to investigations. But the home is good because people are much more relaxed in their home surroundings. You get a much better picture, and you can see what they're doing. You can actually go and look in their kitchen and see if they've set fire to it. In secondary care, what do? We take a full history, a family history, past medical history, look for previous psychiatric problems, check their medication, do a mental state examination, some type of test of cognitive functioning, and that varies in different places. And they may need referral to a neuropsychologist for more sophisticated testing if the diagnosis is uncertain. We'll do the basic investigations if they haven't already been done. Usually they're done before, and arrange for a CT or an MRI scan. So diagnosis. Alzheimer's disease is the most common cause of dementia. It's one we see most often. And if the patient's suitable for medication, we'll offer them medication. Second most common is vascular dementia, and they may need treatment for underlying conditions. They may be hypertensive. And about 10% of patients have mixed vascular dementia and Alzheimer's disease. Mild cognitive impairment. Patients with mild cognitive impairment have problems with day-to-day memory, planning, language, attention or visuospatial skills, but they're not severe enough to actually warrant a diagnosis of dementia. It's a mild thing and doesn't affect normal life, so they can still function fine. And around 10% a year will go on to develop dementia. So again, we monitor these people, follow them up. Post-diagnosis, we offer support and information. We'll initiate the drug treatment if appropriate. We'll put them in touch with local help and support groups. And where I work, the Alzheimer's Society is very active, and they provide lots of carer support, and they provide support for patients as well. They run dementia cafes, carers groups, so there's lots of things we can plug them into. They may need a specialised assessment, depends how they're doing, but they may need an occupational therapy assessment. They might need a social worker, or they might need a psychiatric nurse. We talk about legal issues, and we advise them to make a lasting power of attorney, and we give them advice on benefits. Driving with dementia. People with mild dementia can still drive, Most of them are safe. Most of them know where to give up. The doctor who makes a diagnosis has a legal duty to ask the patient to report their illness to the DVLA. So you have to do that. The DVLA will then request a medical report, and the space for information about driving. One of the questions is, do you have any information about the patient's driving? So I always try and get that. With the patient's permission, I always try and get that from a relative, because it's very difficult. I've got people who score quite badly on the mini-mental who can drive really well, and other people who score well on the mini-mental who drive really badly. Sometimes I go and look at them in the car park. But it's a difficult one. And if you're not sure, you can request a driving assessment. If you're not sure, you can write on the form, I don't really know about the driving, please arrange an assessment. And then the DVLA will arrange for the patient to have a driving assessment. And what usually happens is that they're given a licence for a year, and then another medical report's requested after a year. Ongoing monitoring and treatment. This really refers to people on medication. In my view, it's best managed by primary and secondary care working together. Primary care can monitor medication, but I think they need support from secondary care over difficult issues such as discontinuing medication. It's always very difficult to know when to stop the anti-dementia drugs. And also entering 24-hour care is a big step and difficult for relatives. And I think if they can have support from somebody who is used to the situation, kind of knows when people might need to go, I think relatives find that helpful. Remember, if you're a GP or working out there in the community, sudden deterioration in people with dementia is nearly always due to physical illness, usually an infection, usually a UTI. That's the most common thing when people suddenly... dementia itself doesn't usually progress very suddenly. So if you get people who suddenly are much worse, much more confused, always think of an infection. Okay, so that's a sort of quick run through diagnosis of dementia. Any questions?
Thank you very much. Thank you very much. We'll take some questions now. There's a lady by the aisle, and then a lady or gentleman. She's a lady, and then a gentleman.
Thank you very much for a very informative talk. What medications, could you just give a brief run-through of the medications you'd use?
The first line that I use is donepezil or Aricept, if you've come across that. It's a cholinesterase inhibitor. I use that. There are three of them, but that was the one that came out first, and I got used to using. So that's what I tend to use. So probably sort of 90% of my patients are on that. It's not suitable for people with cardiac problems. So if they've got cardiac problems, then I tend to use memantine.
And do we need to follow it up in general practice? How do we follow that up? Do we need to follow it up with tests or MSU or mini-mentals?
You need to be talking to whoever's initiated the drug, and then you need a sort of local protocol so that you're sure about who does what, because it does vary in different places. There are some places where memory clinics really do all the follow-up, and other places where they just discharge people. So I think you need to talk to your local old age psychiatrist and work out between you what's the best way to do things. I mean, I don't discharge people, I keep them on, but not everybody's like that.
Thank you.
Thank you. Yeah.
Good morning. My name is Petra Baldwin. I work in Leicestershire Partnership Trust. I work with people in care homes. I'm part of an in-reach team. We go in with people who have really quite severe dementia that are having behavioural difficulties at the care home, are struggling to deal with. And looking at the criteria for your assessment, it's very, very detailed. One of the problems that I come across time and time again is people have had lots and lots of assessments, lots of practicalities dealt with, lasting power of attorney and whatever, but what nobody knows is the person. They don't know who the person is. Would you not, as psychiatrist, in that first memory clinic assessment where you're giving a diagnosis, be the person to ask them to start initiating a life story? Start putting together some really vital personal information.
We do. We call it personal history. But in that first appointment, I'll ask people, pretty basic thing, but I'll ask them where were they born, how long have they been married, is this first marriage, what children do they have, what was their job, and that's all written down. So we do begin, you're right, you do need to know about the person.
Yeah, I mean, one thinking is something more detailed along the lines of Ruth's work, of saying to people, you know, there are templates there on the internet. Put together photographs, put together who you are, what your likes and dislikes are. When it comes to somebody with very severe dementia, where I'm dealing with, when you don't know the person, you don't know their likes and dislikes.
Yeah.
Often family can't tell you.
Yes.
We don't know our parents as well as we think we do.
No, you're right there. Yeah.
And you would be the best placed person at that very first initial diagnosis to be saying, go home, have a look on the internet, get together a life story.
Probably not the very first diagnosis, because you're kind of saying to people, you're going to lose your life story, aren't you? So
I don't know. I think we do it with cancer care. I think we do it with other things.
Yeah.
What we don't do is look at people in that sort of depth with dementia. And I think we need to be braver.
Yeah, I
We
think
really
you're
need to be
right.
braver.
It needs to be done. I'd be a bit worried about doing it that first bit, because it's devastating. When you tell people the diagnosis, it's devastating.
Yeah, okay, maybe a couple
bit
of months
later
down
on,
the line.
but you're right. Yeah, maybe after sort of 6 months, a year, something like that, or include it in the information pack.
Yeah.
Good point.
Yes, if I can just add a comment to that, as my name's been mentioned. I'm with another hat on. I'm the vice chair of the Life Story Network, and we promote the use of life stories to help people keep connected with their families, with staff who support them, with their communities. And we would certainly support the view that at the point of diagnosis, not necessarily on the day they get it, but in that sort of follow-up advice and information giving, one of the things that people can do that is very empowering, and people tell us this who've done it, is to start to put together their life story in whatever way is right for them. It can be a photo album, it can be a collage on the wall, it can be a DVD, whatever is right for them. And then that's their life story. It's not part of a medical history, and it's not part of a care plan. Those are tools for professional staff to use in their job. This is a life story for the individual that they can then share with whoever they want to share it with. And it's very empowering, and doing it at the point at which you're able to do it, obviously, is the right thing to do. So, okay, who else had the hand up? Yes, gentleman at the side. Could you say who you are, please?
Yeah. Hello, I'm Tony Ellis, mental health lead for Wigan CCG. And I wonder about, you mentioned having CT or MRI scanning.
Yeah.
I just wondered, how is that mandatory in your opinion? We seem to have them on a ad hoc basis. I would have thought it would help to make a clear diagnosis if everyone had one. And if so, should we do it before we refer people?
I think everybody should have a scan. Years ago, people didn't all have scans, and I worked in an area where there were a lot of doctors, and if a doctor was referred, they always got a scan. And I thought, hang on, if I think that this is what people should have, everyone should have one. So earlier than other people, I started scanning everyone. I think most psychiatrists now would scan everybody. What you pick up is multi-infarct dementia. You pick up people with strokes. About once a year, you actually pick up a tumour, which most of them are untreatable, but at least you know what it is. MRI would actually be better. MRI is better from the diagnostic point of view, but they are much more expensive and very scary for the patient. Most of the patients, I think, a lot of the patients wouldn't actually tolerate it. So, but we do CT everybody. It also depends on the quality of your reports. I've got a radiologist that I've been working with for a long time now, and we kind of phone each other up and email each other, and that's really helpful, because radiologists, my husband's a radiologist, they don't like to commit themselves to a diagnosis, so they won't write, I think this is Alzheimer's, but if you ring them up, they'll tell you on the phone. But no, I do think everybody should be scanned.
If you have to wait for a scan, is it acceptable to start them on an ACI before they have the scan?
Not unless it's an emergency. So if I had somebody who maybe was psychotic or wandering or very aggressive, then I might. But most of the people I see, it's early stage and I wait.
Thank you.
Okay, somebody over there, gentleman, and then a lady in front.
Hello, my name is William, work for MHA, residential dementia homes, actually. On the slide, you list some biochemical and also, I think, clinical tests that are used to diagnose dementia.
They're not used to diagnose dementia, they're used to exclude certain causes. So, for example, you measure people's thyroid function because if you've got hypothyroidism, not enough thyroxine, that can cause dementia. So it's a sort of screening thing to look for causes of dementia.
Okay, thank you.
Hi, my name's Varsha. I'm a care provider. Very similar question to the gentleman behind. I wanted to sort of go through that list of what connection each of those tests had or links they had with being able to include or exclude dementia. Would you?
No, it's just looking for causes, other causes apart from Alzheimer's disease. That's all it is. And again, because this is an elderly population, we pick up a lot of other things. So we quite often end up diagnosing diabetes. Or,
Thanks.
Hello, Sue, Commissioner from Kent. You seem to have quite a broad criteria for referral to secondary care, and worried with the increasing possible prevalence of dementia that you might get over-swamped in secondary care. What work are you doing in your area with GPs to make sure that the referrals that are coming through are appropriate?
well, to me, if a GP refers to me, that's an appropriate referral. But I'm unusual and old-fashioned. And if a GP sends me something, then I think, well, you know, GPs... And I do have very good GPs in my area. I work with extremely good GPs. So, yeah, if they write to me, I'll see them. It's an honour.
Okay.
I don't have inappropriate referrals, but I am unusual in that, I know.
But your services aren't outreaching to GPs to increase their awareness and knowledge around dementia?
We go and give, every now and then I go and give a talk. I mean, actually the GPs are really clued up and very good and refer. I don't know what our percentage is, but it'll be more than 40%. But I do I go out to GP surgeries every now and then and give some talks. And I know the local GPs quite well.
Steve Iliff was talking previously, and he made the point that some memory clinics, 4 out of 5 people referred actually have depression, not dementia, as it turns out. Is that something that you've found yourself, or?
Not 4 out of 5,
Right.
and I'd say often have depression and dementia, often both. And actually, a lot of the people that come to me with dementia and depression, when you start them on the anti-dementia drugs, their mood lifts. So I tend not to start an antidepressant straight away. I'll wait and start them on donepezil, and quite often they'll come back brighter just with that, without an antidepressant.
Okay, thank you.
Hello.
Last question.
Sorry, yes. So I'm Carmen. I work with Four Seasons Health+Care. I just want to ask, how could we reduce the use of antipsychotic drugs with people suffering from dementia who presents challenging behavior?
I think you're probably going to get a whole talk about that this afternoon, but it's going through all the different ways of managing challenge behaviour without drugs is the first thing. And then being very careful with how you prescribe them, small doses, reviewing people frequently, getting them off the drugs as fast as you can, looking for alternatives. The anti-dementia drugs are often a good alternative. And the other thing that I started using that I'm not totally happy about, but at least it's not antipsychotics, is benzodiazepines. I'm having completely stopped using benzodiazepines because all the problems with them, at least they don't actually kill people. So.
Well, on that happy note, thank you very much. That was very informative and very straightforward and easy to understand. Thank you very much.